Good afternoon, everybody, and good morning to our friends on the West Coast. I'm Sarah Dash, President and CEO of the Alliance for Health Policy. Welcome to the 20th event in our COVID-19 webinar series. For those who are not familiar with the Alliance, welcome. We are a nonpartisan resource for the policy community, dedicated to advancing knowledge and understanding of health policy issues. The Alliance for Health Policy gratefully acknowledges the National Institute for Healthcare Management Foundation and the Commonwealth Fund for supporting our COVID-19 webinar series. You can join today's conversation on Twitter using the hashtag AllHealthLive and follow us at All Health Policy. We want you to all be active participants in today's interactive conversation, so please get your questions ready. Here's how you ask them. You should see a dashboard on the right side of your web browser with a speech bubble icon with a question mark, and you can use that to submit questions you have at any time. We'll collect them and address as many as we can during the broadcast. You can also use that icon in case you're experiencing any technical issues. Check out our website, allhealthpolicy.org, for background materials and a recording of today's webinar, which will be made available there soon. Just over 100 days have passed since the COVID-19 pandemic was declared a national emergency on March 13th. Since then, over 2 million people in the U.S. have been infected by the virus, and more than 120,000 people have lost their lives. On March 18th, the Alliance, the Fund, and the NICM Foundation launched this series to provide insight into the COVID-19 response and shed light on remaining gaps in the system that must be addressed to limit the severity in the United States. During the first webinar, we heard from an epidemiologist about the urgent need to flatten the curve. At the time, there were 5,000 cases in the U.S., and we were just starting to understand what that term meant. Since that time, we've learned as a health policy community and as a nation in real time, as the ramifications of the virus have shown us on issue after issue just how interconnected our healthcare system is with nearly every aspect of our society. Today, I'm so pleased to be joined by leaders, prominent health policy leaders in their own right, and leaders of all three of our partner organizations to reflect on lessons learned 3 months into the crisis and lay out considerations as we all work to stem the tide of the pandemic and recover and rebuild not only a more resilient healthcare system, but with it, a more resilient nation. And now I'm pleased to turn it over to my co-moderator, Rachel Newsom, Vice President of Federal and State Health Policy at the Commonwealth Fund, to introduce our panelists and open up the conversation. Rachel, over to you.
Thanks so much, Sarah, and thanks to all of you for joining us. The Commonwealth Fund is so pleased to have partnered with the Alliance for Health Policy on our COVID-19 series. When our organizations began this effort in March, we had no idea we were embarking on a 20-session series to address the critical issues brought about by the COVID-19 pandemic. We hope you take away a few key messages today. First, the COVID-19 pandemic crisis is not over. It's far from over. Whether we are in the first inning or the third inning remains to be seen. But given the move to reopen our nation's economy and our communities, it seemed like a good time to pause and reflect on what we know about the role of COVID-19 and its implications for coverage and access, our delivery system and our frontline providers, and the effort to address system inequities. The Commonwealth Fund has been addressing these issues for 100 years, and our panel will help us address these issues in more depth today. First, I'm pleased to introduce Dr. David Blumenthal, President of the Commonwealth Fund. He'll be followed by Nancy Chalkley, Founding President and CEO and Foundation Board Member of the National Institute for Healthcare Management. Finally, we're joined by Dr. Reed Tuckson, Managing Director of Tuckson Health Connections and the Board Chair of the Alliance for Health Policy. Once again, thank you all for joining us today, and thank you for your active participation. So I'm going to open with an opening question for all of our panelists, and then I'll turn it over to David Blumenthal to kick us off with his response and his opening thoughts. COVID-19 was declared a national emergency, as Sarah referenced, on March 13th, a little over 100 days ago. There's still so many things we don't know. Given that we are nowhere near the end of the pandemic, what can we say about how our health system responded? What's working well? What do you see as the next immediate area for action? And what are the longer term steps needed to move the US towards recovery and rebuilding? David, we'll start with you.
Thank you so much, Rachel, and I want to thank our partners at the National Institute for Healthcare Management and the Alliance for their work on putting on this terrific series of webinars, and of course to Rachel and Sarah for their leadership. I must say that as I look back over the last few months, it is almost certainly the most challenging and difficult period during my 45-year career as a primary care physician, as a health professional, as a policymaker, and as a scholar of health policy. We are watching a train wreck, a public health train wreck in slow motion, and it can be frustrating and perplexing. So I think that now is the time to stop dwelling on the past and to start looking forward and to ask ourselves how we can seize the moment, learn from experience, and make things better. This is a moment of choice for policymakers and for the country as a whole about how to make sure that we learn from our tough recent experiences and learn how to make sure that what we are experiencing now does not happen again. And I think to do that, we need to understand that we are in the midst of 4 simultaneous, intertwined healthcare crises that the pandemic illustrates and compounds, but has not created de novo. The first of these is a coverage crisis. We know that that many people with employer-sponsored insurance have lost jobs. About a fifth of those have insurance in the workplace, and an important fraction of those are now uninsured when they were previously insured. The financing of our healthcare system has been revealed to be incredibly fragile. It depends on the volume of fee-for-service work that is done by our critical healthcare institutions, especially our small practices. Primary care practices and safety net institutions are incredibly vulnerable. Is this a way to support a vital national health infrastructure, especially during times of crisis? A third crisis has to do with equity. Our long history of racism and discrimination against persons of color has risen dramatically to the fore. Twice as many African Americans as whites have died of COVID-19. This is not new, but it's staring us again in the face. And finally, we are now learning that we have a public health crisis. We have no effective public health system in this country. We cannot fight a pandemic without a public health system. We don't have one, and if we don't create one going forward, we will be a victim of the next pandemic, just as we are this one. So I'd be happy to talk more about each of these crises as we go forward and about options to deal with them.
Thanks so much, David. Nancy.
Hi, thank you, Rachel and Sarah. I'd like to add my thanks to this incredible job that you have done with these rapid response webinars. I think they've proven to be a very valuable resource to decision makers, and just want to thank you all for your hard work and leadership on this. I'd like to start my remarks today by recognizing the heroic efforts of people across the country as they face this pandemic, the healthcare workers and the essential workers, the millions of people who stayed home, and those that shuttered their businesses, including many medical providers. There's a lot to celebrate in how Americans have responded to this pandemic, despite the many, many well-documented failures, which I know you've covered in depth in many of the previous sessions. But I think it's important to recognize what has gone right. Today, we're at a pivotal moment in the pandemic. COVID-19 cases are surging in more than half the states. Leaders are under incredible pressure to reopen given the economic devastation and as people grow fatigued of social distancing. And as Rachel said, we're still in the early innings. And of course, this fall we'll also be dealing with the flu season. You know, we talk about testing, contact tracing, and recent advances in therapeutics, but it really seems that we are largely counting on the arrival of a vaccine. And while there's lots of reasons to be optimistic about the discovery of a vaccine for COVID-19, the history of vaccines for viruses is actually a cautionary tale. So it does give me some concern as we address some of these forward-looking issues. But as David has alluded to, one of the things the pandemic has done is laid bare the flaws in our healthcare system and in our society, especially around health inequities. The human stories of the pandemic are of the fortunate majority, those of us lucky enough to be able to work from home, enjoy time with our families, and marvel at how productive these Zoom meetings are. And it's also the stories of the unfortunate minority, those that can't work from home, don't have reliable child care, and are contracting COVID-19 at high levels and suffering severe health consequences and even death. These human stories are playing out across an unfair healthcare system rooted in an economy experiencing historic levels of wealth inequality. People who are Black, Hispanic, Native American, and Asians are 2 to 3 times more likely to die from the virus, depend on work that places them on the front lines, or suffer pandemic-related economic hardships. So one of the key questions is, will this crisis push us to meaningfully address the underlying structural issues in our healthcare system and in our society? COVID-19 has changed life for millions of Americans. And even after it is controlled, it threatens to accelerate a mental health, substance abuse, and loneliness crisis in America. And we need to ensure that our healthcare system is equipped to deal with this, both in the short and medium and long term. There are many reasons to be optimistic. Our system is adjusting. Telehealth is here to stay. The speed of innovation is changing as learning communities have sprung up everywhere, and we begin to use techniques like virtual clinical trials. Care is being safely shifted to less intensive settings. We're doing less low-value care. So there are many things that we can capitalize as we move forward. But as David alluded to, many, many problems remain. So now more than ever, we must work towards a more equitable healthcare system and society. And that means protecting the most vulnerable as we recognize and address racial and other forms of discrimination. So I'm very much looking forward to today's discussion. Thank you.
Thank you so much, Nancy. Dr. Tuckson.
Good. I will extend on David's admonition as we look to the future. We have to learn from the past. So I see the good and the bad. The good news about what we've seen is, number one, the values of physician and health professionalism have stood the test of time. That the commitment that young health professional students make when they graduate, their Hippocratic oath, that those are enduring values that inform our society and are profound and were profoundly demonstrated through this crisis. Number two, the ability to flex and expand the hospital delivery system with remarkable innovativeness, the capacity that so many of our hospitals demonstrated to create new wards, to create new ICU capacity, and doing it with a rapid turnaround was, I thought, extraordinary and praiseworthy. Number three, the ability to create a real-time learning laboratory, which facilitated identifying novel clinical insights from the provision of care, even in a chaotic environment that we had, with rapid real-time dissemination of those insights and continuous modification and adjustment of treatment protocols. Our journals responded well. Our professional societies responded well, and we learned a lot and used in knowledge, continually upgrading and changing and modifying clinical performance. I thought that was extraordinarily useful. Number four, the advancement and adoption of telehealth is a watershed moment in the future in the history of healthcare. The bad things are, number one, we don't really have a health system. So to talk about how the health system performed is probably a non sequitur. What we have is a broken system where not only, as David has indicated, with the brokenness of public health, but the connection or the interconnection between public health and clinical medicine, that part is clearly broken and something that really needs to be attended to. We also know that the slowness, not only of testing is a problem, but what is not getting enough attention is the suboptimal capacity of contact tracing. And it's not just the capacity of contact tracing, but the ability to gain the trust of the American people in being able to to get at that. Number two, what is really bad is the politicization of science and public health. The inability to overcome the legacy of distrust by people of color and other populations. The attacking of public health officials and the intimidation of them through the politicization is important. Much of this is outside of the control of the health system, but let us remember and not take ourselves off of the scrutiny table. Be clear that we have failed in our health system to maintain or build those trusting relationships that could have withstood the challenges of the moment. So while exacerbated by the behavior of too many public officials, political leaders, making it worse, but unfortunately, we did not have the resiliency built into the system that we should have had. Number three, what is bad is the unpreparedness, not only of testing, but the unwillingness to document subpopulations, epidemiological trends, so that we could identify hot spots early. And then lastly, I think the bad from what we've learned is, and we'll talk about this, I'm sure, in a few moments, the new challenges that this provokes for affordability to care and access to care. So it's a picture of good news and bad news, unfortunately, more on the bad than the good.
Thank you so much. And now I'm going to turn it over to Sarah Dash for our next question.
Great, thanks, Rachel. Well, thank you to each of you for really outlining just a tremendous scope of really the good, the bad, and the ugly as we look over the last few months and look forward. So I'd love to follow up, Dr. Tuxson, just on your last point around affordability and coverage, and this has long been a challenge in the country. We've made strides, but certainly are not there yet as far as coverage and affordability. And as you and the others have pointed out, we also have, of course, these tremendous health disparities that COVID has really shined a spotlight on, but that we've known about for a really long time. We know those disparities really extend into the realm of coverage and of affordability. So how do you see that intersection playing out as we move forward? I mean, does this crisis create an imperative to take a closer look at coverage and affordability, kind of equity? Like, will that alone solve the problem? Can you start us off there?
So clearly, before COVID, we had an affordability crisis with extraordinary percentages of American people unable to afford their copay or their fundamental insurance, and the number of people that were in collection for medical debt. Clearly, those are again exacerbated and exemplified greatest by subpopulations groups, people of color, those who are poor. So those issues were clearly in front of us. Now we will have to have a complex equation as we reset what the cost of care will be, as we expect hospitals to maintain the capacity to have excess capacity to meet surge, not only for the later stages of this, but for the next pandemic? Will we have more capacity and redundancy built into the system or not? That's a decision that will have to be made in terms of the bricks and mortar. We have to understand what supply chain dynamics are going to look like, and whether or not those supply chain redundancies will be built in, and what the economics will be for what will, compared to pre-COVID, appear to be inefficiencies built in. You subtract from that perhaps the savings that could come from telehealth if used intelligently, or will telehealth be an augmentative, an additional cost, and not taking costs out of the system? So those are the unknowns. Inevitably, we are going to certainly see that nothing about this epidemic or this pandemic will lessen the cost challenges, and that means then that people who are dependent, who are low-income people or dependent on public funding and public insurance, are going to have a very hard time. And I would leave my answer concluded with, in particular, in terms of your question, the real sensitive spot for me is what's going to happen to Medicaid reimbursement. Because if we find now that Medicaid reimbursement continues to be suboptimally low and providers are unwilling to take Medicaid, which will be a disastrous implication for so many people in this country, then we are going to not only worsen disparities, but we're also going to set ourselves up again for having rebound opportunities for pandemics such as this with COVID.
Great, thank you so much, Dr. Texan. Dr. Blumenthal, you talked about the coverage crisis, the equity crisis, and the delivery crisis is also intertwined. What are your thoughts on this intersectionality and as we think about moving forward?
Well, Sarah, I think we face a critical choice in the next election about whether we are one country when it comes to protecting people from illnesses that affect everybody, or whether we're going to remain divided the way we have in the past. This epidemic has shown that when people don't have health insurance coverage, they don't get care they need, they don't get into the system, and they remain infectious and create vulnerabilities for their co-citizens in ways that is now graphically clear. So the question we have to face is whether we now see coverage as vital to our national welfare. And if we do, there are plenty of options going forward, ranging from the most extreme, Medicare for all, to modest changes in the Affordable Care Act that will greatly expand coverage and affordability. With respect to affordability, there is a sweet spot where prospective payment, capitation, and all the variations on that can create more stability of financing for our delivery system, while at the same time creating accountability for providers of care that will cause them to be more judicious in their use of services and also in their pricing of services. So I think that's one of the great opportunities we have right now, which is to say to our providers of care, look, this pandemic has shown that your dependence on fee-for-service volume leaves you incredibly vulnerable at a time when pandemics are likely to recur. Wouldn't you prefer to have a guaranteed source of revenue that in return for taking responsibility for a group of patients? And I think that could give incentives for cost control as well as for stability in financing.
Great.
Sarah, if I could just, Sarah, could I just augment one thing that David said, which is extremely important, and I really like his response, and that is, in addition, the value-based reimbursement models that he described are also a huge incentive for the delivery system to partner with public health, because there are clear incentives there as you look at the holistic care of the patient and not just piecemeal fee-for-service, to be concerned about the precursors of illness, the identification of disease early, and being able to mobilize assets and resources to keep the patient from tipping from risk factor to actual manifestation of disease. So all of those harbor well also, in addition to the great points that David has made, to stitching together the public health and the clinical care delivery system more effectively.
Great, thank you so much for that. And we want to get into a whole set of questions around delivery system next. I want to follow up on something that David said, and then also turn to Nancy to see if you have any thoughts on this, as it relates to coverage and affordability. Obviously, we can't ignore the economic impact of people, staying at home. We know we're in probably the worst economic crisis since the Great Depression, with tremendous job loss and, a lot of job loss among, the folks who just don't have the opportunity to stay at home and those sorts of things. And of course, jobs are tied to coverage. So David, maybe I know you and the fund have done a lot on this. Can you comment on that? Like, what do we know so far? What's the evidence so far about job loss as tied to coverage, and what are the equity implications there?
Well, we know that about 2/5 of the folks who have lost jobs have employer-sponsored insurance. Either they or their dependents are covered under employee plans. And of those 2/5 who have lost jobs and have employer-sponsored insurance, 1/5 have become uninsured. Some of them have gotten onto Medicaid, some have bought plans on the Affordable Care Act marketplaces. Some have been furloughed and still have insurance while they are furloughed, though they might lose it if they lose their jobs in the future. But 1/5 of those people have joined the ranks of the 30 million uninsured who were uninsured prior to the pandemic. So there is a direct, in an employer-sponsored insurance regime, there's the direct link between the strength of the economy and the level of coverage that we have and the numbers of uninsured that we have. And this, of course, is a moment when we have to ask ourselves, and there are many answers, is employer-sponsored insurance the basis for a humane and predictable and adequate level of insurance coverage in this country?
Great, thank you. All right, so Nancy, I want to ask you what you think of this, and I want to weave in a comment we just got from our audience around, that they don't think the primary issue is lack of coverage and affordability, but the audience member talked about, it's more a problem of poverty, of education, of work conditions, of environmental exposure, food and nutrition, long before anyone needs healthcare. So maybe, as you think about these issues around health equity and how coverage and affordability fits into it, like how do you see it fitting into the bigger picture?
Great. Thank you, Sarah. And I'll just build on the previous speaker's comments as well as addressing specifically more the equity. We've been dealing with coverage and affordability for a long time, and we've made some progress on coverage with the passage of the ACA, but of course, the Supreme Court is hearing the case on it now, where 23 million people might lose their coverage. Medicaid expansion didn't happen the way we wanted it to happen across the whole country. State budgets have been devastated. So there's a lot of global issues, but more specifically in terms of the health disparities. As I think the questioner wrote in, it's not enough just to provide coverage. We know people don't even take up some of the Medicaid coverage that has been put out there. And even if they do, they may not have access to physicians. So this is a complicated question. And then it's made so much more difficult by some really specific issues related to inequities. And so, yes, there is a great imperative to act, and the pandemic has helped people recognize that it's not only the right thing to do to deal with healthcare disparities, but it's actually in everyone's self-interest. Our health is interdependent and our economic lives are entwined, and the pandemic has really highlighted that to the general population. And I think there's a growing recognition that we're still dealing with implicit systemic racism and discrimination. And so if you can call it good news, the good news is the problem is clearer and more people know about it. But this is a very hard problem to solve, and it goes beyond the general discussion of coverage and affordability. We need to address the broad array of social determinants of health. And what do we mean by social determinants of health? We're talking about income and employment, social status and support, education and child development, and the environment. And these are very large, difficult structural issues related to the healthcare disparities. So, and many key macro trends are making it harder to solve these problems. For example, the concentration of wealth and the vulnerability of low-wage jobs to automation. So bottom line is that we need to move the needle on this, and we need to make the healthcare system more accessible. Yes, by promoting broader coverage and by making it more affordable. But low-income people, healthcare, they can't afford healthcare. The average household makes $50,000 a year. That's very difficult to afford a regular premium. So yes, we need to do coverage and affordability, but we also need to give people real access to insurance and to physicians. And we also really need to deal with these very tough issues related to social determinants of health. And also, we need to eliminate implicit bias in the healthcare system. So yes, give coverage. Let's make it affordable. Let's finance our public health programs, but also let's deal with social determinants of health. But also let's eliminate implicit bias. And at NICM, we funded a study recently published in Science that was for the first time documented the degree to which a spending-based algorithm fails to identify Black patients with high health needs, resulting in significant racial disparities in access to care management services that could improve patient outcomes. And while no one intentionally designed these algorithms to be biased, it still captured systemic undertreatment of African Americans. And of course, once this was recognized, all the parties involved wanted to fix this. So it's a very complicated problem. Yes, coverage. Yes, affordability. Yes, better funding and broader access to public programs. Yes, let's make sure there's a better connection between physicians and minority communities. But let's also tackle the social determinants of health and the implicit biases in our healthcare system.
Thanks so much, Nancy. This is Rachel. I want to turn the topic a little bit back to the delivery system and frontline providers. And just to add, we're at about 12:30. We're going to wrap up just before 1. We definitely want to talk about economic recovery and some public opinion pieces here. So I'm going to ask our esteemed panelists to be short and concise with your answers if possible. I know it's really hard and these are very difficult questions. But David, I'm going to start with you on the delivery system. We've been talking about how the COVID-19 pandemic have really put frontline providers in the delivery system kind of face to face with unprecedented challenges. Hospitals in some parts of the country have been both overwhelmed by surges in patients, and some are dealing with the dual issue of both overpowering demand as well as the vanishing of profitable services that often provide their fiscal stability. A really difficult place for health systems and providers to be. Given where you stand from your vantage point, what does the evidence tell us about both how our health system and our providers have been weathering the storm, and what do we need to do right now to really ensure the resilience of our health system and our frontline providers?
Had to unmute there. Thanks, Rachel. It's a very important question. First, I want to say that on a personal level, our healthcare providers have, as Reed said, really risen to the challenge. And as the father of 3 physicians who have been involved in caring for COVID patients, I see the cost and anxiety that has exacted every day on their behalf, from them and their family. But as Reed said, they swore an oath and they go to work despite the threats. But the institutions which they work, and often the small practices in which they work, have proven unstable under stress. And I think we have to look at the fundamental causes of that instability and ask ourselves whether a health system that is so vulnerable in times of pandemic is a health system that is properly financed and properly organized. Is it a vital infrastructure like our electrical grid or our communication systems that can't be allowed to collapse when the winds when swift winds, hurricane force winds blow through our economy? If we decide that it is such a vital infrastructure, then I think we can begin to think about ways of financing it that are more predictable and more stable, while at the same time providing accountability for both cost and quality of care. And that's where I come back to switching much more to a value-based or prospective payment, budgeted, prospective budgeting kind of approach, so that whether demand is up or whether demand is down, the financial welfare and sustainability of that system is protected. One can, of course, add on aliquots of funding to create surge capacity, which I do think we will need to do in the future. And it might be easier to do that if we have the kind of control over spending that would be implied, and predictability of spending that would be implied by more value-based prospective reimbursement than we have had in the past. So I think we need to look carefully at that, and also we need to recognize that this pandemic, before it is over, under even the most optimistic scenarios, is going to knock the wind out of and threaten the existence of critical services like primary care, behavioral health, and our safety net institutions. They need help right away, or we will not have a functional healthcare system. So a lot to do, but I think we can get our hands around it.
Thank you so much. Dr. Sexton, I'm going to have you follow up on that. You mentioned Medicaid providers. Talk about frontline providers, serving communities where we can see the need, and yet there's a disconnect between recovery dollars that have gone out to support providers and the Medicaid providers that are very much on the front lines. Can you say a little bit about kind of the safety net providers and the Medicaid providers specifically, and how important it is to make sure that they are positioned to both continue to meet the need of COVID-19 patients, but also make sure that they are still open and still available to meet ongoing health needs as we move into other stages of the pandemic?
I think David was correct in, again, pointing out that there are some subpopulations within the overall delivery system that are particularly in trouble. And I spent a lot of my time the last couple of years with rural hospitals and inner city hospitals and care providers. And there's no question that this is a real concern. It was a concern before COVID, as we saw the steady depletion of the number of rural hospitals that are available. And as we are seeing the number of rural hospital patients who are being sued by rural hospitals for unpaid medical debt. So both of them are on a death spiral going forward, which is a problem that will only be exacerbated post-COVID. Similarly, as I mentioned with Medicaid populations, and also in the urban and inner city environment, is the reimbursement level itself is so suboptimal. So as I see well-meaning care providers who really want to take on more of the burden of those who are underserved today, and trying to get people who are from the substance abuse community, returning citizens from incarceration, homeless poverty, all of those kinds of people who are not only vital as transmitters of this pandemic, but are also needing care for the long run. These folks trying to sign them up for Medicaid, but finding out that when you do that, the reimbursement levels are so low that you basically take your finances and put it upside down. Meanwhile, as you mentioned in your question, folks who seem to be doing quite well wound up getting the lion's share of the money. The only other thing I would say very quickly, because I know we have to be brief, is we have to be really clear now about the underlying theses that we love to talk about. Social determinants of disease. People love to talk about that now, and finally it has got its moment in the sun. What doesn't get enough attention is the destruction of the social safety net inside of rural America and inside of cities. And so as long as we're going to trumpet the importance, and correctly so, of the social determinants as a wraparound for how we will pay for total holistic care, we have to really understand that America is going to have to now, coming in the middle of this COVID pandemic and coming out of it, we're going to have to decide to really put literally our money where our mouth is, and make sure that we are enforcing the vibrancy of the housing, the food markets, the ability to have people to be able to have places to recreate. All of those things require resources. And right now, they are being woefully underaddressed.
Thank you so much, Dr. Tuckson. Nancy, I'll just have you kind of finish us out on this topic. You mentioned the social determinants, and I think given Dr. Tuckson's comments, it's very clear that the healthcare system per se has only a small reach and level of influence into the health and the well-being and lives of our community. So we talk a little bit about the importance of kind of bringing in non-clinical support, community-based support to meet the social needs, especially of our most vulnerable populations.
Right, well, thank you. Yes, I think that as you were alluding to, if we really want to fix the inequities in our society, we have to go beyond the healthcare system. We need to bring in more social workers and other people like that. We need to do a lot more research about what works as well. And we need to roll these things that we know that work out. And so a great example of that is we've known for a long time about how high an ROI early childhood intervention is, especially between the ages between 0 to 2, especially with nurse practitioners. We need to look more about using people, social workers, nurse practitioners, of course, our medical workers, to really get into these communities and help them make systemic changes in the trajectory of their lives. I would like to address some of the comments about the resilience of our healthcare system, because I think we really want to think about how to move the system forward and building on what has happened during the pandemic, taking advantage of some of the positive trends that people have talked about, like telehealth and the decrease of the use of low ineffective care, et cetera. But I think we also want to think about protecting against greater concentration in the delivery system. Because the hospital systems and the physicians have been so hard hit, we may see more concentration in those areas. And we know that leads to higher costs and no improvement in quality. And so I think that the system has been hit hard. We first need to put out the fire. I think everybody is stepping up. The CARES Act, generous funding, but as Reed pointed out, it's very unevenly going out, especially to our public health systems. But hospitals are stepping up, physicians are stepping up, insurers are stepping up, drug companies are stepping up, but we don't want to just, Zeke Emanuel had a great op-ed in the New York Times, and it said, will 2020 be the year that medicine was saved? And I do think we want to think about taking this time and thinking about our delivery system to make it more sustainable and more cost effective.
Great. Thank you so much, Nancy, and to all of you. I do want to get a question in around public health, because there's been several questions from our audience about that, and a number of you mentioned it. And Dr. Tuckson, if I could start with you, when you talk about how we build a stronger public health system, what is one thing you think that policymakers could do right now to get that process going?
Well, number one is to really put money into the CDC and through the CDC into the states, and then directly governors to put money directly from the government coffers of the state government into the public health system. That is absolutely job one, because they don't have the resources that they need to be able to do their job. And to ask them to do more with so little is impossible. After that, Secondly, and I'll make this my only other comment on it, is that we have to continue to stitch together the medical care system with public health so that we have a continuous flow, that we are able to have everyone have a stake in the overall outcome of care for the individual. And that's where I think we have to be intelligent about how we use the changing reimbursement to the provider system. And we also have to be much more meticulous at holding public health accountable. The clinical care system has an extraordinarily large number of important performance measures that allow us to transparently track the quality of what they do. Public health, not so much so. And so what we have to do is to have everybody adopting the same goals and then be accountable for their part of how they contribute to the overall healthiness of the population and the overall return after a disease experience to the individual.
Great, thank you. And let me just say, we're getting a number of questions in about more details on how all of this can work, who should coordinate it, back to the delivery system, the value-based payment, and how healthcare markets should work. We're not going to have time, unfortunately, today to address all of those questions. But what I want to assure our listeners is that each of our organizations is really listening to your questions, and that as we look to our future programming, we are definitely going to be addressing many of these questions. So I'd like to turn it over to Rachel for our next question.
Thank you, Sarah. All right, I'm going to turn the topic again one more time. We have gotten a lot of questions about this, and it's something that we've been seeing at the Commonwealth Fund in some of our own survey research as we look at public opinion and how that's changed or stayed stable during the course of the COVID-19 pandemic. So after 4 months of the quarantine, shutdown, social distancing, and racial tensions, as well as devastation of our economy, we are a nation divided. In some communities, taking recommended health precautions such as distancing or mask wearing are seen as a political commentary. As an extreme example, we're seeing reports of local public health officials needing physical protection in some communities. How do we depoliticize this issue and advance pandemic preparedness as a shared goal? I'm going to start with Nancy.
We are a divided society. There is no question about that. And it is a real sad commentary that something as simple as wearing a mask to protect those around you is considered by some a political statement. But it is the world that we live in, and we need to work in that world. And I think it's important to continue to have local communities working at the very micro level, talking about what can be opened and what not, and how fast to open, etc. Because we're so divided, if it comes from a federal level, I think that people reject it. Even at the state level, many communities reject it. I think what we need to do is a better form of education of why it's important to wear masks, why it's important to wash hands, why it's important to do social distancing. Because as much as we would like to mandate it, that's not going to work in our divided society. And so we need to go to education and to increase the voluntary efforts and keep it at a local level. As much as I would like to say we should just mandate it, I just don't think that will work.
Great, thank you. David?
Well, there's an old truism in political science that people get the leaders they deserve. And I don't know if that's true or not, but I do believe that leaders matter, and that consistency of messaging and consistency of speech makes a difference in the mood and tenor of the country, and that gets communicated from the top down to the lowest levels of our society. So it will always be true that there will be some folks who won't agree with any requirement that society seems to put upon them. But I also believe that fundamentally people are sensible and responsible, and that if someone can make the case convincingly and in a trustworthy way that non-pharmaceutical interventions, so-called NPIs, social distancing, wearing masks, staying home when you don't need to be in large gatherings, that those make a difference to them and to their loved ones. And the way to start creating a public health revolution in this country is by leadership that emphasizes the importance of collective responsibility and what we can do for each other. This is not a partisan thing. You have seen Republicans and Democrats emphasize the essential role of community responsibility in Americans' lives. And whether it's church or whether it's a local club or whether it's a political party, people do come together and do things together, and harvesting that goodwill, I think, will get us the leadership we deserve, and the leadership will be really important.
Thank you, David. And finally to you, Dr. Tuckson.
I think the fundamental here is can we create a society that actually cares about the humanness of others? The reason that people are willing to be so self-indulgent to not follow guidance or advice is because at the end of the day, too many of us have been grown up in a culture where we disvalue human life, and especially those of others who are different from ourselves. And so I've lived in this reality for 70 years almost now in my life. And I know that every time I go out into the world, I'm going to be facing a number of people who really don't care about my humanity. I'm a secondary thought. And as we are seeing many political decisions that are being made in this country today about this virus and the need to return to work, it says that we're prepared to write off hundreds of thousands of people's lives. And when so many of those are people of color, it really does make us wonder about the sense of caring. So within that, what do we do to change that? I think we're starting to see something different as we start to see the number of people of all races, all age groups, coming together to make a peaceful statement all around this nation about humanity, about our relationship, one group to the other. That is, I think, extraordinarily important. And then the last comment I would make is the only way that we ultimately get past this is that even those of us who have been wronged so much throughout our lives are going to have to stand down on our own sense of tribalism. Everybody is going to have to make a decision that at this point in American history, finally, at long last, this may be the moment where actual humanity takes over. And my responsibility to you and yours to me, and the fact that we are bound in an inescapable web of mutuality finally takes heed. I am hoping for that, but I've been at this almost 70 years, and I'm not sure that I'm overly optimistic, but I'm still trying.
Well, thank you, Dr. Tuckson. It's hard to end on a more powerful note than what you just said. We do have a few minutes left, though, so I want to ask each of you to comment if you have any final closing thoughts, anything we have not covered yet in this webinar. Again, as we move forward, and as the old Robert Frost poem says, clearly we have miles to go before we sleep as individuals and as a society, but we can keep moving forward. So let's just go back to Dr. Blumenthal. Any final brief parting thoughts for us and for our listeners this afternoon?
Well, thank you, first of all, for your excellent moderation, Sarah and Rachel, of this conversation, and thanks to my co-panelists for their excellent observations. I want to come back to the moment in which we find ourselves. It's a moment of decision for this country. I think this pandemic and future pandemics that are inevitable are existential threats to our economic welfare, to our ability to govern ourselves, and of course to our health. And we have to face that existential threat with the same commitment and vigor and intensity with which we faced the last World War and the World War before that. It is at that level of threat. We are going to probably lose more lives, could very well lose more lives to this virus than we lost in World War II if things keep going. And we need to view it that way and summon up our better angels, because it is something we absolutely have to do better with in the future.
Thank you. Nancy, do you have any final parting thoughts for us?
You know, I would like to end on an optimistic note, the same way I started with my remarks. I do believe in Americans, that we will come together. I mean, not just Americans, but people in general. I've spent much of my life overseas. That as people, we will come together. We are being sorely tested because of our tribalism and the fact that some people still don't get the danger of this pandemic. But I do believe that our healthcare system will hold together, our society will hold together, and we will continue to see these heroic actions by individuals.
Thank you so much. Dr. Tuckson, back to you.
Yeah, I would say that from the putting on my hat as the chair of the board of the Alliance for Health Policy and an honored collaborator with our friends at Commonwealth, is that I think what we really want to do is to keep now rolling up our sleeves and digging underneath these bigger philosophical issues down to the mechanics of how to move things forward. I think the climate is there. I think everything that we have talked about, both the challenges, the concern, as well as the areas that we've identified that are success or that give us the opportunity to change and behave, now need to be translated into tangible, concrete actions. I believe very much that it is possible to achieve bipartisan solutions. I believe from everything that we have learned at the Alliance for Health Policy over our 25 years is that there are people of goodwill on both sides of the aisle who are prepared to work together. And what we have to do now is to create an even more fertile environment that allows those conversations to be driven by facts, best evidence, best science, best experience, put those facts into the hands of responsible people on both sides of the aisle. And I am optimistic that this is the moment we will start to get things done. I am very confident that people of goodwill on both sides in our congressional bodies can actually come together and do the right thing. We are going to be there to help make that happen.
Thank you so much, Dr. Tuckson. I would echo those remarks as well. So we are at the end of our hour, but not at the end of our work. I want to thank each of you, Dr. Tuckson, Dr. Blumenthal, Nancy Chalkley, and each of your organizations for your partnership, for your hard work, and for your leadership. I want to thank everybody in our audience for listening in, and to each of you for your leadership as well, because it's going to take all of us to move past this pandemic and to rebuild. I'd like to just ask everyone if you could complete the brief evaluation survey that you'll receive immediately after our broadcast ends, and feel free to listen in on the recording that will be available on our website soon. So this is goodbye for now, but not forever. We will have much more programming back to you. Please share your ideas, your questions, your concerns, and any topics that you would like us to cover. We really do listen to your feedback. So again, David, Nancy, Reed, and Rachel, my co-moderators, thank you so much for joining us. Rachel, any final words?
Nope. Thank you to all of our panelists and all of our attendees for making this such a fantastic and action-oriented series.
Thanks, everybody. Have a great afternoon.
Take care. Bye-bye.
Bye.